So next is groin abscess, V18. A 37-year-old man presents to the ED with a painful left groin swelling. What is your differential diagnosis? So differential diagnosis: painful lump in the groin starting from the skin. It could be infected sebaceous cyst or abscess in the skin, like a boil. Uh, Subcutaneous tissue, lipoma, muscles and tendons, inguinal or femoral hernia, artery, aneurysm, veins, saphenopharynx, lymph node, lymphadenitis, nerve, schwannoma, psoas, bursa, arterial aneurysm, and infection. How will you assess the patient? So I will take the history. Was it sudden or gradual in onset? Any history of systemic symptoms like fever, malaise, unwell, and any progression. Is that swelling reducible on lying down or recurrent, any other swellings? Then I will do systemic examination. Then I will look at the swelling site, size, shape, overlying skin, underlying structures, mobility, fixity, reducibility, transluminability, auscultation for bruit, and check for the generalized lymphadenopathy and examine the leg for the skin lesion. The lump is 4 centimeter, tender, hot, and fluctuant. He has a temperature of 38 degree. He attends the local medicine clinic. What is the most likely diagnosis? So he needs septic screen. Most likely diagnosis is a groin abscess secondary to the intravenous drug use. Most important differential is femoral artery pseudoaneurysm. Other differential reasons include reactive lymph node, incarcerated hernia, lymphoma, tuberculosis, and undescended testes with infarction. What are the best next step in the management? So he needs admission, IV antibiotics, analgesia, urgent duplex or CT angiogram. If the collection is separated from the artery, proceed with incision drainage with the packing and cavity and attain the microbiology cultures. Your FY2 junior medical officer sees the patient before you do. Perform the incision and drainage procedure in the emergency department to help facilitate the discharge. You are called to the scene due to torrential bleeding from the wound. How will you manage this instruction? I would instruct my FI to stop and put pressure, apply direct pressure on the bleeding, and I will organize the theater immediately by telling the anesthesia theater staff, and we will organize the blood for him. And before anesthesiologist and nursing staff on the emergency and your operative plans ready, O negative blood, prep and wrap the lower abdomen and both thighs after intubation anesthesia, all while applying the digital pressure over the bleeding point. So I will give the left Rutherford Morrison incision, go extraperitoneally, locate the iliac vessel, and I will hold the proximal control of the external iliac artery. And once clamped, digital pressure can be eased off to facilitate dissection and involvement of the femoral artery. Then distal control is by the longitudinal incision in the groin. I will dissect the common femoral artery, profound femoral artery, and this superficial femoral artery, SFA. And then I will debride the abscess, mycotoid pseudoaneurysm to healthy arterial wall and send tissue for culture, irrigate obviously. If the groin vessels cannot be dissected out, call for vascular surgeon. If defect on the SFA is less than 50% of the diameter, then can be primary repair with the interrupted fibroprolines. Sutures can be performed, and deep tissue coverage of the vascular structure is desirable to prevent desiccation and blowout. A 3 centimeter segment of the SFA, proximal common femoral artery, is destroyed by the abscess, and the surrounding tissue is inflamed and impossible to dissect. You have the external iliac artery and the distal common femoral artery clamped. Control of SFA and DFA. What are your surgical options? So this patient needs revascularization, vascular reconstruction versus ligation of the both ends. So ligation or oversewing of the proximal and distal ends can be done to avoid the risk of vascular reconstruction and osmotic blowout in an infected field and recurrent bleeding or exsanguination. In about 50% of the patient, limb is salvaged by the collaterals. Preservation of the common femoral artery bifurcation into SFA and profunda femoris artery is preferred to safeguard the viability of the leg and to avoid the need for major limb amputation. So IV drug users do not generally have any usable veins for vascular conduit reconstruction. So synthetic bypass inevitably become infected and should be avoided. How will you revascularize this leg? So one option is that we should fetch his autologous grafts, and CFA replacement with contralateral great stiffness vein graft may need to spiral panel the graft due to the size mismatch. Then tissue coverage is imperative as sartorius muscle flap closure, and synthetic grafts avoiding the infected field tunneled through the clean tissue planes, obturated bypass, ringed PTFE bypass from the common iliac artery through the obturator membrane and right common femoral artery to mid left superficial femoral artery ring through the PTFE bypass and left axillary to, so it's non-anatomical bypass. Thank you.